everyone for joining us this evening. We're very happy to have you guys here. I know it's a very, very hectic time of year, but we're very appreciative of your time here. You know, we put this presentation together because this year we know it's going to be a very unique season where we're going to have more shots than just the flu shots that we're used to. It's the second year of the pandemic, and by now we have our COVID vaccines, and we also have adult immunizations that a lot of the times have slipped through the cracks during the pandemic. So I think throughout the pandemic, pharmacists have really established themselves as beacons within their communities, and immunizations are one of the most important services that we can provide, and they're the #1 most essential preventative measure for vaccine preventable diseases. So we'll talk about some of the vaccine considerations and barriers that you may come across in the next few months, and some tips for these as well.
Great, and to get started with, I'd like to introduce Dr. Molly Yang. So Molly is the brains behind Whole Health's programs that are really one of the core offerings that you get when you join Whole Health Pharmacy Partners. We do like to provide, education to the pharmacy community as well, whether you're part of our group or not. So welcome. If you're not with Whole Health, we're very happy that you're here. No matter what type of pharmacy setting you're a part of. My role is primarily in pharmacy operations with Whole Health, and I'm James Morrison. Molly, I think you set the stage very well that this is going to be a flu season for pharmacy unlike any other we've seen before. So very exciting times.
Yeah, definitely. And just a quick note to everyone that please feel free to post in the chat if you have any questions. James will be moderating. We'll also make the slides available after the presentation, so no need to rush to take notes on those. And there's my emails also at the end of this presentation if you have additional questions, and we will be sharing a survey at the end of the presentation as well. If you could kindly fill that out, we would really appreciate it.
Yeah, so feel free to put your questions in the Q&A would be the preferred, but we'll also accept the chat box, and we'll try and address as many as we can through the presentation. We're going to cover a lot of ground and many different topics related to flu in the pandemic. So hold on to your seats. We'll try and give an in-depth covering of each topic, but feel free to ask questions as well as we go. I just want to take this opportunity to let folks know that Whole Health recently celebrated an important milestone. There's a picture there of myself and Molly at the event for our 100th pharmacy celebration that happened less than a month ago at our Whole Health location in Welland. And the inside joke with Whole Health is that it took us so long to plan that event that we actually have opened or had another 25 pharmacies join us. So currently we have 125 pharmacies operating under the banner, and we're set to have about 150 by the end of the month and end of the year in 7 provinces. So if you are looking for a change in your pharmacy banner, or you're opening a new pharmacy, please reach out. We'd love to hear from you. So one big thank you to our friends at Pfizer. So Whole Health does a number of vaccine programs throughout the year, and Pfizer has always been a strong supporter of us for quite a long time. So we're grateful, Pfizer, for your support for this presentation.
Thank you, Carol, as well. Okay, so I'll take over for the next few slides here. I just wanted to take this slide to go over some goals. So the point of this presentation is to clearly review the updated flu vaccine products and who they should be used for, but we also wanted to provide a thorough review of some of the other vaccines because, when we see a patient, we really want to consider their full picture, not just the flu vaccine that we may be administering during that appointment. And so we will go over some of the main recommendations around adult immunizations and, importantly, pneumococcal vaccines, for which we recently had a few pharmacist focus groups as well. So we'll go over the finding of those. In terms of the agenda, we'll first go through influenza and the vaccines that are going to be available this year. Then we'll go over some of the recommendations for this year. We'll go over the pharmacist's role and some gaps that we elucidated from our focus groups. And then finally, we'll review by going over pharmacy operations and plans for what you can do this flu season. Okay, so we'll start off with an overview of influenza and vaccines. And this is meant to be quick, a quick review of influenza. Why is influenza important? Of course, it's important because it is a significant cause of morbidity and mortality. So it's one of the top 10 causes of death in Canada, along with pneumonia. So with influenza and pneumonia together, that accounts for about 6,000 to 8,000 deaths per year in Canada. And it's about half of those that are associated with pneumonia and influenza each. In terms of the season itself, the season goes from November to April. Usually the pharmacy program starts in late October with a peak in that November season as we're trying to make sure that as many patients are prepared and protected in advance of the season itself. In terms of the number of cases that we see, that actually peaks in January. And the transmission of influenza is, of course, through respiratory droplets that can travel up to 6 feet and on fomites. So that would be surfaces where those respiratory droplets sit on, and the virus can actually live for up to 48 hours on there. So a little bit different than what we know from COVID. So I put in this slide here to show a comparison of the symptoms between different conditions that we're going to be talking about. So more so COVID, flu, and pneumococcal pneumonia. What the key takeaway is that with these conditions, these symptoms are very difficult to discern. So this is significant, especially with the precautions around COVID and antigen testing and PCR and isolation, that whenever these symptoms arise this season, our first thought will be COVID. And so I think it's really important to point out to patients, and a reason why they should get vaccinated for COVID, for flu, and for pneumococcal pneumonia is that, you know, they don't want to have to go through that stress, of course, of, you know, having to go through that unnecessarily. But of course, as well, these conditions are also very dangerous and can be deadly.
Yeah, Molly, that's a really important slide. And I think for me, the key takeaway looking at this has been there's so much overlap between symptoms, no way to tell if you've got flu or COVID. So always assume it's COVID until proven otherwise. If you're with Whole Health, Molly's created a number of really great infographics that you can use on your social media as well to encourage people to have an understanding about, you know, the COVID scare that could potentially happen because of the overlap of these symptoms. So encouraging folks to get their flu vaccine as soon as it's available.
Yeah, definitely. And last year, what we saw was a bit of an abnormal season with only about 80 confirmed cases compared to the usual 50,000 or so cases. But we have to remember the context of what happened last year and the fact that a lot of time was spent in lockdown. A lot of people were more careful. So we do expect to see a little bit of a resurgence this year with flu. I'll go through the slide quickly as well, but refocusing on flu, there's not just the acute symptoms that we just talked about on the last slide. We're also concerned about the sequelae, and that includes both direct effects on the respiratory symptoms and indirect effects, which can exacerbate many conditions and cause complications like encephalitis, myocarditis, and other heart conditions, and lead to hospitalization, which further leads to disability and ventilation, and can also exacerbate conditions like diabetes as well. So with influenza, who's at risk? So as you can see here, the risk factors include children who are under 5 years old, patients with chronic health conditions, and not just respiratory conditions like COPD, also cardiac conditions, diabetes, obesity, all count towards that as well. Pregnant individuals are at risk as well as patients living in nursing homes and facilities. Of course, adults 65 plus are at higher risk, and we'll discuss that in a later slide, as well as Indigenous peoples in Canada. Beyond that, certain individuals are also, even though not individually at higher risk, they're at risk of transmission to those high-risk patients. So that would include healthcare professionals like us on this webinar here, household contacts of the above patients. And I didn't mention before, but especially in households which have a child under 6 months, that child is unable to get a flu vaccine as of yet. So it's really important to educate the family around that, making sure everyone's protected. Childcare workers and service workers are also at high risk of transmission. Provincially, the programs will differ in terms of who is prioritized here, but often in the beginning of the flu season, we will try to target those high-risk patients to make sure they're protected before the flu season sets in. Okay, a quick review of what the flu virus is actually like. So within the family is Orthomyxoviridae, but most significantly for us, influenza is broken down into influenza A and B, which is further broken down into different subtypes like H1N1 and H3N2 for influenza A, which is more responsible for those pandemics. And then there's also influenza B lineages, which although are less common, may also cause serious disease as well. A common question that we may get from patients this year is, is COVID related to the flu vaccine? Does the flu vaccine or the COVID vaccine protect me from the flu or vice versa? So definitely it's important to educate them that they do need to get both vaccines. Another common question that we may get is why we need to get an annual vaccine. The fact around that is that flu is highly mutable, even more so than COVID. So with each replication of the virus, there are changes to the genetic structure. And sometimes these are inconsequential, but other times they can cause significant mutations in both antigenic drift and antigenic shift. And the way in which these vaccines are made each year is that the WHO takes surveillance data of influenza variants around the world, and then they make a recommendation on what is to be used in North America. I did put a note here, which we'll go into the next slide, that influenza A, especially H3N2, accounts for the majority of influenza cases with an especially high burden in patients 65 and up.
Molly, we've got an interesting question before we move on to the next slide. So does the efficacy of the flu vaccine wane over time? And I think you hinted at that. If so, is there an advantage to delaying administration of the flu vaccine until the onset of flu season, which I understand is close to the end of November?
Yeah, so good question there. I would not delay the flu vaccine as soon as we get the vaccine. Patients should be getting vaccinated because it's not like right after you get the vaccine, you're automatically immune to the flu, right? It takes a couple of weeks for that immunity to build up. And as I just mentioned on the slide as well, there is, in terms of why we need to get that repeat vaccine every year, it's more so to do with the fact that there are variants that may surface year to year. And so one vaccine one year may not be as effective the next year. Okay, so this next slide, why are older adults most affected? It's due to immunosenescence, which is a weakening of the immune system with age. It's a twofold impact where the immune system is less responsive, which leads to more, making patients more vulnerable to infection, and also less responsive to vaccines. We see as well older adults contribute significantly to the morbidity and mortality of influenza, making up the majority of hospitalizations and deaths. And beyond deaths, of course, there is significant morbidity associated with severe disease where if they're hospitalized, many patients may lose the ability to perform activities of daily living. So very significant. And certain vaccine products have been developed to address these factors, which we'll review in a slide coming up very soon. Okay, so with flu season 2022, I know this is a little bit of a busy slide, but I like to have all of my data on one slide sometimes so we don't have to switch back and forth. So we'll go over the available flu vaccines in Canada. There's two categories with flu vaccines. There's trivalent vaccines and quadrivalent, and they're essentially the same each year, except for the addition of an extra B strain with the quadrivalent vaccine. So the quadrivalent vaccine has two A strains, which we just mentioned are more, lead to more cases of severe disease and are more significant for older patients, and then also 2B strains as well. So we'll go down the list. So first we have the live attenuated vaccine, which is FluMist, which is the intranasal product. It is a live vaccine, so it has different contraindications than the others. And there is a little bit of a list here, but it's not exhaustive. You also, as healthcare professionals, wouldn't want to get this vaccine because we are, dealing with more patients who are immunocompromised, and we wouldn't want the virus shedding because of that. The next vaccine, so inactivated vaccines as well. These three, they are pretty much interchangeable and pretty much have equal efficacy and safety. We also have inactivated cell culture-based vaccine, which is the FluCellVax Quad. It can be used in ages 2 and up. The difference with this vaccine is that it's not egg-based. So a lot of the rest of these vaccines are produced in fertilized eggs. So technically, if you have a vegan patient, this is the most vegan option because it's grown in an immortal mammal cell line. And because of the fact that it is grown in that cell line, it theoretically has a better match because it doesn't have the vaccines that are grown in eggs may be more adapted to the eggs. So it is theoretically, oh my gosh, I'm stumbling a little bit over my words. Sorry, everyone. But theoretically, it is a better match with the cell-grown vaccine. The last one for the quadrivalent vaccines is the inactivated high-dose vaccine, which is the Fluzone high dose. And this is for patients 65 and plus. This contains actually 4 times the antigen content for each strain. So the most important thing that I want to note here is the change in volume. So for the rest of these injectable vaccines, it's 0.5 milliliters, whereas for Fluzone high dose, it is 0.7 milliliters.
Yeah, and Molly, that's important to emphasize. The high dose Fluzone Quadrivalent, it's a pre-filled syringe. So if you look at that and you think it appears to have more volume, that's correct. It should be slightly more volume as it's 0.7 mils. So don't think that you need to evacuate 0.2 mils from that syringe. You don't. There is a question here, Molly, in the chat about FluCellVax age criteria has changed to 2 years and up now. Is that new?
Yes, this is new this year.
Yeah, so there's a couple of things to consider there. There's the approved age for the vaccine, but also the pharmacist or technician's ability to inject based on the age of a patient. So those are separate things. So pharmacists in different jurisdictions across Canada and technicians in some can provide flu shots for different age groups. So don't get confused with if you're in Alberta thinking this is approved for a 2-year-old, thinking you could vaccinate that patient because that province is 5 and up as an example. So I just wanted to draw that distinction.
Yeah, definitely. That's a great point, James. A lot of the information that I'm going through, because Whole Health is now a national banner. It is general clinical information that Nancy has presented and what is indicated, whereas there may be provincial differences within your own jurisdictions. Another note for the Fluzone high dose is because of that additional volume and the fact that it is a higher dose, there is a higher rate of reactions. So something to definitely counsel patients on to look out for.
One more point, Molly, about safety for these vaccines. I was on a call for one of our health regions today in Ontario, and they were mentioning their concern that pharmacists and pharmacies that have been running COVID clinics may have been drawing up several doses at once. And there's a concern that we might do that with flu vaccines as well, which could lead to an administration error. So their recommendation was not to pre-draw the flu vaccines. As you know, on the slide here, most of them are good for 28 days or more. So the recommendation was not to pre-draw those so that there would not be that risk of an administration error.
Yes, and most of these vaccines will come in the pre-filled syringe, although again, it depends on your public health unit and the distribution, whether you will get the pre-filled syringe, or there's certain ones that I've listed on the bottom there, which are also available in a multi-dose vial. Okay, so moving on to the trivalent vaccine. So the only trivalent option that we have is the adjuvanted inactivated vaccine, which is Fluad. It's for ages 65 plus, and it contains an adjuvant inside. And what that does is it stimulates the immune system to produce a stronger immune response. Due to that as well, it is associated with a higher rate of injection site reactions as well. And I'm sure that since there are so many options, we will see many questions coming from patients. We will review in one of the coming slides on individual decision-making and what you can say to patients when they're trying to make that decision, or if they're asking you for your recommendation.
So I know there's a lot going on in this slide, but we wanted to provide a bit of a summary of the whole country all at once for folks, and looking at the different types of vaccines that are approved in the various jurisdictions. So that one that Molly just ended on in the last slide, the trivalent adjuvanted vaccine, that one is only part of the publicly funded program in Ontario. So the rest of the provinces don't have to deal with that additional vaccine. So if you hear Molly making recommendations or myself throughout this presentation, that is only relevant for Ontario. You'll see that high dose quadrivalent, and even last year the high dose trivalent, is starting to make more publicly funded listings across the country. And you see that line on the chart here, how some circles are green. Well, that's a province that's listed that product for anyone 65 and up. And the red circles are when there's some more parameters around who can access that vaccine. As well, looking at the last line there, the intranasal, there's some provinces that have publicly funded flu mist in their supply, and that isn't necessarily at pharmacy in all of those provinces. Molly, do you have anything to add?
Nothing else to add to this slide. We do have a couple of questions that have come up. So how about flu cell vax age in Ontario? So in Ontario, we're authorized to vaccinate over the age of 2. And we have another question, any detrimental effects to give Fluzone to someone under 65? So there's 2 Fluzones. There's the Fluzone quadrivalent standard dose and the Fluzone quadrivalent high dose. The high dose is only indicated for someone over 65.
Yeah, so if you were to administer that vaccine, it would not be indicated in someone under 65. And I actually hear that question a lot every flu season.
Oh, really?
So it's a good one that came up. So for the individual asking about Ontario specifically for that particular vaccine, we should note that Ontario program also has Afluria, a quadrivalent vaccine, which is not indicated under 5. So we have to be careful in Ontario, maybe put up a cheat sheet of all the vaccines.
Yeah, exactly. Okay, so we'll go over some of the new updates with flu programs across Canada, and I'll let James take it away here.
Yeah, it's exciting every year to see what's happening across the country, and what's happening in New Brunswick might be a sign of what's coming next for your province. So we saw this year in New Brunswick the addition of the high dose quadrivalent for all those 65 years and over as part of the publicly funded program that's available in pharmacies. And I understand they've purchased enough of that vaccine for the majority of the seniors in New Brunswick. Also good news that the pharmacy program has lowered the age down to 2 years and up. So if you have, that's a change from last year to this year. Last year was 5 and up. And also our pharmacy technician peers have been added into the program in New Brunswick. So those technicians who have the technical permit to administer drugs by injection can participate in the flu program. New Brunswick is the second province to formally introduce pharmacy technicians. The first was Nova Scotia last year. So hopefully we'll see that trend expand across the country. So Quebec has made an interesting and somewhat confusing decision that they've analyzed data from recent studies from Quebec and other studies, and they were looking at the number of flu-related hospitalizations and deaths. They found that healthy children 6 to 23 months and healthy people 60 to 74 years of age didn't have higher risk of flu-related hospitalization or death compared to the rest of Quebec's healthy population. So they are no longer recommending flu vaccination for these groups. However, patients, certainly they're still eligible for the publicly funded vaccine through pharmacies for those adults, not, of course, the 6 to 23 months, but it's no longer recommended, but patients can certainly have the vaccine for free. And Ontario, this question came up just the other day from a pharmacist. Actually, last year, midway through the program, we lowered the age eligibility for patients to receive a vaccine from a pharmacist in Ontario. So a pharmacist can now immunize a patient 2 years and up with a flu vaccine in Ontario pharmacies.
Okay, so these next couple of slides will go over kind of the role of pharmacy and what the gaps are that we can really fill for our communities. And I see a question there for between Fluad and Fluzone high dose. Is there a preference for 65 and over to get one over the other? Let's talk about it on this slide. So I think the overall communication from NACI and from all public health units is that any one of these vaccines is safe and effective. For patients under 64, any one of the quadrivalent vaccines can be used, but of course, taking a look at what ages they're indicated in and what ages, again, are allowed within your provincial jurisdiction. And also, just a note here that the live attenuated flu mist is only for ages 2 to 59, so not up to the 64 age. When we are talking about seniors and the vaccines that they're able to get, there are a few more options. So in general, if there's only one type of vaccine available in your pharmacy, the recommendation is that the patient should not delay vaccination. So regardless of it's any one of these 3 vaccines available, they should still get vaccinated instead of delaying to get a different type of vaccine. If you do have the option, however, there is good evidence of superiority with the high dose quadrivalent vaccine, which they looked at the high dose trivalent vaccine that we had in the past compared to the standard dose trivalent vaccine. We see when in this comparison that the high dose resulted in a 34% increase in efficacy compared to standard dose. So we do have good evidence and strong evidence for the high dose quadrivalent vaccine. Taking a look at some of the other options, because the high dose quadrivalent is so new, there is no direct comparison with the high dose quadrivalent with these other vaccinations. And there's insufficient evidence to make a preferential recommendation between high dose quadrivalent and the adjuvanted trivalent vaccine. But when we do consider use of the adjuvanted vaccine, so that would be Fluad, compared to the standard dose vaccine, which would be the standard dose quadrivalent, given the increased burden of disease associated with influenza A, especially H3N2 in older adults, better protection against influenza A from that adjuvant being added on may be more important, especially in those with multiple comorbid conditions and compromised health statuses. So the order that you would be using for these vaccines would generally be using that high dose quadrivalent vaccine, followed by the adjuvanted trivalent vaccine, followed by the standard dose quadrivalent, which is still effective and safe for patients within this population.
Molly, you've taken something very complex and simplified it. So that was really excellent and I'm sure helpful for the audience. So the key takeaway for a senior 65 plus, if you have the high dose quadrivalent, that one is first priority. If you're out of that one, offer them the adjuvanted trivalent. If you're out of that one, then move to the standard dose quadrivalent, and they're all effective for preventing flu in these patients. So don't feel bad about that.
Yeah. One point that I'd like to just remind everyone as well, that for patients aged 2 to 9, so especially in the jurisdictions where we might be seeing younger and younger patients than we have before, these patients will need a second dose, a booster dose of their flu vaccination within at an interval of 4 weeks if this is their first flu shot. So if they've never gotten a flu shot before and this is the first one they're getting from you today, you need to book a booster appointment in 4 weeks. Okay, a question that is relevant to some of the recent changes that we've heard from NACI. Should vaccines be co-administered? And we've been waiting on this, this update for a while, especially with COVID vaccinations. What NACI recommends is that COVID vaccines may be given at the same time or anytime before or after other vaccines, including live, non-live, adjuvanted, or unadjuvanted vaccines. So for all of the flu vaccines, NACI recommends you're able to provide a COVID vaccine at the same time. A note here that this may vary by province because certain provinces may choose, with especially if a live vaccine was given, with the flu-miss vaccine, which is the live vaccine, they may consider doing an interval of about 2 to 4 weeks or so before another live vaccine. But this varies. An important thing to note as well here, it may be intuitive, but of course using different needles and syringes for each vaccine that is given. And it's also important to note that beyond COVID and flu vaccines, NACI makes a strong recommendation that each vaccination appointment is an opportunity to address all vaccines that the patient is eligible for. So they recommend giving all of these vaccinations at the same time, at the same day, and using an opposite arm or by separating by at least 1 inch from the first vaccine if you are to give several vaccines at the same time.
Molly, there's a question here that relates to the last slide. What if a 2 to 9-year-old got their first dose last year, but only got 1 dose? Do you give them 2 doses this year?
Oh, that's a really great question. I don't have I'm not sure how to answer that. Have you come across that, James, before?
I think the answer is you would just carry on and give them 1 dose this year. And you probably will encounter those patients because I think it's quite uncommon, unfortunately, that pharmacists, started doing flu vaccines some years ago. And I think at times we might have not rescheduled that second dose. So it's a really great reminder that we put that in this year's presentation to make that part of your workflow. If you see it's a 2 to 9-year-old and you learn that's their first dose, as I'm immunizing a patient, I always ask, have you ever had a flu shot before? And those ones that say, no, I haven't, really do stand out. So make note of that, especially if it's one of these 2 to 9-year-olds, and schedule that next dose while you have them there with you.
Yeah, definitely. There is one extra point that I wanted to talk about on this slide, and it is the Fluad vaccine, which of course is the adjuvanted high dose, or the adjuvanted vaccine for seniors that we just talked about. Are we able to give that with every single vaccine out there? So when we take a look at the vaccines that we may consider, pneumococcal vaccine, we can definitely give with all of these flu vaccines and COVID vaccines. But with Shingrix is actually an adjuvanted vaccine as well. Because we don't have any data for using 2 adjuvanted vaccines together, it is a recommendation to avoid Fluad and Shingrix being used together. And so if we do provide Fluad, or if we do provide Shingrix, then it is recommended to wait at least a 1 to 2 week interval before going ahead with the Shingrix vaccine.
So Molly, in planning these 2 vaccines, which one goes first?
Fluad, definitely.
Right. So we're in the flu season soon. So start with the Fluad, please.
Yeah. Okay. So we wanted to put a slide in here just to address any questions that might have come up about COVID-19 vaccines. Of course, this is always changing. It can change very quickly in terms of what provinces are doing, and there's a lot of variability within provinces as well. We know for 3rd dose, certain provinces have chosen to go ahead with immunocompromised patients, offering that to immunocompromised patients. So for example, Ontario, Alberta, and Quebec. There's also certain provinces who offer 3rd doses for travel-related reasons, which we do get a lot of questions from patients about. So it is happening in Saskatchewan, Alberta, Manitoba as well. The question about myocarditis and pericarditis and mRNA vaccines. With the myocarditis and pericarditis risk, we did see recent additional data come out where there may be more of a risk that we see with Moderna. Not all provinces have responded to change their recommendations, but in Ontario, the preference is for Pfizer vaccines in ages 18 to 24. It is important to note here, though, that Moderna can still be used with informed consent because of the fact is that the vast majority of these patients with myocarditis or pericarditis, they're very mild and self-resolve. I wanted to put an additional note on here as well around pediatrics, because we may have heard for the past little while about upcoming pediatric doses. So we do hear that it is coming up later this year, potentially around the holiday season. And that's really interesting for the pharmacy because you may begin to see younger patients coming in for both the flu and COVID vaccination at the same time.
Molly, there's a comment here in the chat about the children who only got 1 dose during the first flu season they got a shot, and now this season should receive 2. So I think we'll have to look into that one and perhaps send a note to all of the registrants just to make sure we're giving the best recommendations. So thank you, Adrienne. We'll definitely look into that.
Yeah, definitely. Okay, so this slide goes over some of the common barriers, and this is actually as a result of some of the focus groups that we conducted with our pharmacists about adult immunizations, both in the pandemic and before the pandemic as well. So I've listed some of the key barriers that we talked about within our focus groups and some of the actions that we identified that could potentially help with these recommendations and providing these vaccines. The first thing that we talked about is vaccine hesitancy. And I think it's important when we talk about vaccine hesitancy to really explore the root cause if the patient allows you to. I've linked a great resource by the BC CDC below, which talks about vaccine hesitancy, which talks about motivational interviewing, which talks about different ways you can communicate and ask patients respectfully about their vaccine hesitancy. So that's a great resource for sure. The reason why I wanted to bring this up is because certain causes of hesitancy can be addressed by education from the pharmacy, while others may not be as much. And so it's definitely important to maybe tease that out so that you can relate to the patient at their level, right? The next barrier that I want to talk about that was identified as well is the lack of patient self-identification of risk. And this is especially so in patients who may be more so in the quote unquote older population, where we see that we can hear them say, maybe, that's not for me, that's for older patients, I'm not there yet, I don't need this. Those may be common quotes that we often hear as pharmacists. And to address things like that, it's about making it personal. So identifying individual risk. So are there comorbidities or are there concrete things that you can tell them that show them that they're at higher risk? Perhaps it's about talking about the impact of the disease itself on activities of daily living or activities that they're passionate about, so that they can see in context that it is important to get the vaccine to make sure they're protected. Another component we talked about was patient lack of awareness. So patients who have generally heard of the vaccines generally receive the information that you give a little bit better. We heard that if patients haven't heard about it, conversations can be a little bit longer to address their concerns or issues. They might say something like, my doctor never told me about it, or I don't need it as a part of routine vaccinations, so I don't need it at all. So when being approached with this, it's important to use the available resources. So using visual aids, using pamphlets, using posters to help educate them, and also to provide balanced information as well, because sometimes we've heard the sentiments from patients or from other healthcare providers as well, where we don't want to give unbalanced information because we don't want to erode that trust, right? The last thing I want to talk about as well is pharmacy time and resources. And of course, this is significant during the pandemic. And often with these adult immunizations communications, it's not a conversation that you may have with a patient in passing. It's not just a quick, hey, you need this vaccine. And oftentimes the patient may not just agree to it on the spot, right? We hear a lot of patients who hear the information when you speak to them at first, but then need to come back at a different appointment to maybe ask you more about it or to get the vaccine at a different time. So to help address the time and resource limits around providing these recommendations, definitely to include your team in this, making sure that they know who to screen for, who would benefit from these vaccinations, wherever possible, including it in that flu screening form, so that even if you don't have time to act on it right now, it can be added to the patient profile, or it can be added to another to-do list. Passive education where possible with material during the waiting period. So posters, brochures for patients to kind of help make that decision when you may not have the time to go through every single reason with them. And as a last point, we did also talk about cost a lot during our focus groups. It can be quite a big barrier. It does vary by geographical location and where the pharmacy is as well. I think the overall comments that we ended up on was the fact that you don't assume that patients will not get it due to cost. It's always, patients are always thankful for hearing about the recommendations on how they can be better protected, as many of these vaccines are life-saving. Okay, so I included this summary slide in here because I wanted to provide a great resource to look back on to really hammer down some of the key points as to why certain vaccines are recommended, which populations they're recommended in, and why it's so important to get vaccinated, and speaking points for these patients. So with pneumococcal vaccinations, we have Prevnar, which is a conjugate vaccine, and we also have Pneumovax. We know with Prevnar, since it's a conjugate vaccine, it offers more robust immune memory compared to Pneumovax, and it also reduces the nasal carriage of pneumococcal bacteria. And so to get optimal protection, however, patients should be getting both of them. So all patients 65 plus, and you also want to consider it for all patients 50 plus as well, as we say on this bottom point here, that patients 50 plus have a very high burden of disease of pneumococcal pneumonia. They have the highest rate of ICU admission and ventilation as well if they're hospitalized. We do also want to offer it to patients 18 and up with medical conditions, which we'll go over in the high-risk eligibility in the next couple of slides. And again, of course, it is one of the top 10 causes of death in Canada, along with influenza, as we covered on the first slide, and there are significant complications associated with pneumococcal pneumonia. Another vaccine that you want to provide for older adults is, of course, the herpes zoster vaccine. Shingrix is 2 doses at 0 and 2 to 6 months. There is public funding in Ontario for this, and it's important to note that throughout Canada, it was recently changed to Schedule 2. So pharmacists, you can make these recommendations, and patients may purchase from the pharmacy as well. With private insurance, however, some private insurances will count pharmacists as a prescriber, while some may not. So there is a little bit of variability there. And for Shingrix, you want to offer it to patients 50 plus due to the complications of shingles, including post-herpetic neuralgia, vision loss, scarring, and infection. And we do have a great comment here that it's ages 65 to 70, but there is an extension because of COVID. So it's up to age 71. So very important to point out as well for our pharmacists in Ontario. Okay, so I added this chart here about putting risk into individual context because it relates back to the findings of our focus group. And, you know, for the patients who say this isn't for me or I don't need it, this is a way to kind of address their risk factors with them to make sure that they understand why they need a pneumococcal vaccine. So for example, the rate of pneumonia in patients with diabetes, as we see on the top half of this graph here, is actually 3 times higher than healthy patients in the same age range. And it's even higher for conditions like immunodeficiency, and with each chronic condition, it is significantly higher as well. You can also see here, as I mentioned in the previous slide, that patients 50 to 64 actually have more of a higher rate compared to that 65 plus age range. And this may be due to some of the fact that patients 65 plus are more so vaccinated against these vaccines. So we do want to make sure that we're providing these vaccines to the patients who have such a high burden. I've included the algorithm here just to help out with providing both Prevnar and Pneumovax. Of course, we want to give Prevnar first to get the best immune response. There's also less time if we give Prevnar first because we only have to wait 8 weeks compared to a year with Pneumovax followed by Prevnar. This was another important thing that was brought up in our focus groups, the fact that pharmacists may feel a little bit confused around provincial coverage around pneumococcal vaccines. It is one of the more complex vaccines to wrap your head around. So with Prevnar, we've actually created, as a part of our pneumococcal program coming up, these helpful resources that point out in which conditions Prevnar is covered within these provinces. And so you can see here that in certain provinces, all of these conditions which put patients at high risk of pneumococcal pneumonia are covered by the public program, but in certain provinces, they're not. So this really opens up an opportunities for pharmacists in these provinces where there is not a check mark to make that recommendation to those patients. It is also important to note that the criteria in different provinces differ. So for example, in Ontario, this is ages 50 plus where it would be covered, whereas in other provinces, it's usually ages 18 plus. So the takeaway here is that there is a lot of variability, and just because it's not covered by the public program doesn't mean that these patients would benefit less from pneumococcal vaccination, not necessarily, right? So we must look at the overall picture, and I hope with this tool, it'll highlight some of those opportunities for intervention.
Yeah, Molly, a couple of things. So Marina has been kind enough to send us a couple of references to the group chat about that question regarding a patient who only got that 1 dose when they should have had 2, being in that less than 9 years age group. And the recommendation is just to offer them 1 dose the subsequent season, as I originally stated. So thank you very much. And there's a link there to the CPS with an article to review. And Jazz is asking us to please repeat what you said regarding the Schedule 2 status of Shingrix and whether a prescription would be required for a pharmacist to administer that.
Yeah, so Shingrix has recently been changed to a Schedule II status across Canada. So you would not require a prescription from a prescriber for the patient to actually purchase the vaccine and get it administered in your pharmacy. You may require a prescription for it to be covered under their personal private health plans, however.
Yeah, so the issue there, Molly, from my perspective would be if we bill that prescription as the pharmacist prescribing it, the insurance probably would accept it, but they might audit it later and say that they don't acknowledge the pharmacist to prescribe that medication. If you're dealing with a health spending account, I think that's different. That wouldn't be subject, I don't think, to being audited the same way an adjudicated prescription claim would be. So those nuances do exist, but patient could pay and submit, for example.
Okay, so on this next slide here, I go over a similar chart, but for youth and young adults this time. We know for meningococcal B, patients who are aged 10 to 25 are recommended to get the vaccine, especially if they're living in that group or conjugate living situation, which increases their risks of getting transmitted pneumococcal infections with meningococcal infections. So with meningococcal vaccines, we have Trumemba, which is a 2-dose vaccine, and also Bexsero as well. With Trumemba, we do see a little bit of a broader coverage based on the technology of the vaccine itself. And the reason why we want these patients to get vaccinated is because meningococcal disease is very quickly progressive. It's difficult to distinguish. It's very similar to severe flu symptoms in the very beginning, and it's very quickly fatal as well. And even in the patients who don't pass away from it, unfortunately, 1 in 3 survivors experience disability. Another condition we'll want to consider as well as HPV with the Gardasil vaccine. This is for patients aged 9 to 26 who are recommended to get this vaccine. They may have gotten it within school programs, but due to the disruptions with COVID-19, there's been a lot of gaps for both of these vaccinations in terms of getting it within school. So you may consider also giving it for patients 27 to 45, depending on their risk of new HPV infection. So if their risk of new sexual partners, if they're going to be more at risk that way. And the reason why we want to give it, it's not just related to genital warts, it can also cause cancer, and not just genital cancers, it can cause neck cancers and also different types of cancer as well. So I've included this slide on CARD here. So CARD is a tool that has been developed by the University of Toronto. It's been developed by Sick Kids as well to help prepare especially younger patients for vaccinations through strategies that have been proven to reduce that fear and anxiety and fainting around vaccines. It has been very tested in more so public health related settings, but I wanted to put this up here as a resource if you're interested in checking it out. We won't say too much more on CARD because Full Health has actually been working with Dr. Anna Taddeo and U of T to develop a pharmacy pilot project on CARD. So stay tuned for that. We'll definitely be coming out with that soon, as well as the findings and how it relates more so to independent and retail pharmacy. I wanted to include this slide as well on injection technique. I won't go in depth into this because I know we're running low on time, but this is just a quick review on how we should be injecting. It's important that we always palpate and properly landmark and not just eyeball. A helpful thing for this, of course, is to make sure the patient is wearing something that allows you to access the area, because oftentimes when we're struggling to pull a sleeve up or moving skin out of the way, it can really affect the landmarking. And just as a last note, that whenever we're doing vaccine clinics or providing vaccinations, we have to make sure that we have appropriate epinephrine in case of allergic reactions. With flu season, the observation time is 15 minutes, although as per NACI, it can be 5 to 15 minutes, provided provided physical distancing cannot be maintained, and if there's no history of an adverse effect following an immunization from the patient, and if a chaperone is also present to take care of the patient as well. I've provided some common symptoms for anaphylaxis, which you can see there, as well as the Canadian Immunization Guide, which was recently updated this year to promote the 0.5 milligrams in patients over the age of 12 and over 64 kilograms as the most appropriate dose for patients based on the weight of 0.1 milligram per kilogram. So we'll go over some operational tips, and I'll just pass it on to James here.
Thank you, Molly. And I'm going to move through this a little quicker. We're coming to the end of the hour. We really did cover this quite well in last year's flu webinar, and this is just a quick summary. So if you're looking for a more in-depth coverage, our flu webinar is available on YouTube or on our Facebook channel from last year. So please check that out. But some key considerations for this year, pre-screening patients for symptoms of COVID-19 before they come into the pharmacy. If you can use, providing consent forms ahead of time, having them submitted to do that, or even phone screening, or even active screening at the door before they come onto the premises. All of that is a good idea. Optimizing the encounter, which to that means, making good recommendations around which additional vaccines could be given concurrently. If you're dealing with a pediatric patient who's now eligible for COVID, if you could time both vaccines at the same time, or a more senior patient, if they would benefit from a pneumonia vaccine, making sure everything's in order for having their flu shot and their pneumonia vaccine concurrently at one appointment. Completing paperwork in advance, so conveying those important records that pharmacies need to keep based on your jurisdiction to the patient ahead of time, whether that's using an IT infrastructure or through email. Immunizing whole households together, so group appointments where you would bring in, spouses and kids, or couples. Using technology, so there's many different technologies out there to facilitate booking appointments for vaccines. A couple of our favorites would be MedMe or MedAssist. Both are great. So either one, or using another technology, really to streamline your process. Trying to discourage folks from walking in for appointments and referring them only to your appointment-based channels, so that you can really control who's showing up and when, so that you never have crowds of people in your pharmacy looking for their flu vaccines. Next slide, Molly. And a quick reminder, there's been some confusion around PPE. What do I need to wear while giving flu shots? While the only important requirements are the surgical or procedural mask and a face shield are strongly recommended based on CPHA's best practices. And those guidelines have been updated recently, so please have a look. If you have an individual who's doing like a long day of vaccines, perhaps they want to wear a gown as well for sessional use up to 6 hours. Gloves are not required and actually discouraged because they might affect one's commitment to hand hygiene. So really, unless you have a good reason that you needed to wear gloves, it's actually recommended not to. And I see there's a couple questions. We're going to park them just till we get through the last few slides, I think, Molly.
Yep, definitely. And I'll go through these last few slides quickly. They're just a summary of what key points I want pharmacists to take away from the presentation. So number one, when we're talking about opportunities for adult immunizations, the who, the when, and the how. So who, we're definitely looking at patients age 50 plus, the older adults, especially in the beginning of flu season, where we want to provide those recommendations around pneumonia and shingles so that they're fully protected throughout the season. And then in ages 10 and 25, so the youth where 10 to 25, so in youth where they're more at risk for other conditions like meningococcal meningitis and HPV, we do want to also recommend these vaccines as well. When we provide it, so there's different types of interventions that we can do. Most easy thing that you can do is that passive screening, right? Where you can provide it on booking within a flu screening consent form, or you can provide materials during waiting times that they can look through in the waiting area, posters, brochures that patients can read and self-identify. We also want to provide recommendations during vaccination, so that precious time when the patient has time with the pharmacist to review any of their questions around vaccines, we want to discuss our recommendations at that point as well. The how, as James had already mentioned, posters, pamphlets, handout, and then using technology, generating lists of patients. If we're able to have a flu clinic in advance, so we know which patients are coming, we can generate lists where it would be important to call the patient and relevant to make these recommendations to. So this is a quick summary again of why we want to stay up to date with our adult immunizations, with our other eligible vaccines and our flu shot, and why we want to do it now. So number one, of course, these vaccine preventable diseases can be very deadly and significant, especially in some of our older patients, which we know are already at risk for influenza. We want to do it because of individual risks. So there are certain patients who have comorbidities that put them at significantly higher risk compared to healthy adults. And we want to provide reasons for why they would want to get vaccinated. So risk of complications and disability, and really connect with patients on why these vaccines are really necessary. We want to protect our families and our communities. Studies have shown that often when you have recommendations around vaccinations, recommending that they'll protect themselves is great, but patients also really respond when you talk about how this can help their community, when you talk about how this can help protect their family members. So bringing up herd immunity in that, bringing up protecting those who cannot be vaccinated within our communities. And of course, with COVID-19, as we had previously mentioned, because of all the limitations that we have around COVID, we want to avoid that stress and unnecessary COVID testing and isolation that may come from influenza or that may come from pneumococcal pneumonia. So making sure that we get vaccinated to reduce the risks of those. And this is just a quick summary slide of the pharmacy workflow as well, where there are interventions that you can try at each point. You don't have to do them all, but perhaps it's one thing that you may incorporate in the beginning of the season. And as I mentioned before, if you want to incorporate screening for other vaccines, if possible, if you don't have time to follow up at the vaccine appointment, it can be added onto the patient profile for you to follow up at a later date when flu season cools down a little bit, or it can be followed up with the patient's physician as well. So at this point, James, do we have any other questions?
Yes, we do. So there's questions about needle length, but first, let's get to this question about offering like a numbing agent, whether we think that's appropriate for someone who's scared of needles.
Yeah, definitely. I think it's a great opportunity. We have these agents available within our pharmacies, and we can definitely use that for patients, especially for those who are, needle averse and afraid of needles. So that's definitely an option. You want to provide it about 20 minutes in advance of the immunization, and you can provide it by putting on the anesthetic. You can put some plastic wrap over it so it doesn't get, all over the area, or it doesn't get smudged while they're waiting for their vaccine, and then providing it that way.
So there's a couple of questions there about needle length, Molly. So one in the Q&A about suitable needle sizes for different age groups, and then another one about infants and children. where they've seen recommendations using a 5/8 inch to a 1 inch, but how do you decide which one to use? I'm not sure, Molly, if we wanted to wade into those questions tonight since it's kind of outside the scope of this presentation. I don't want folks to think this is a supplement for injections training because it's not. It's more clinical, but if you had comments, I did put a link to a reference there that discusses this, but there's lots of references out there.
Yeah, definitely. There's a lot of references that can help with that as well. I think in general, when we're looking at a patient and seeing how much tissue is there, the 5/8 needle is fine if, in your professional opinion, it's the most appropriate for the patient. Often for pediatric patients, we may choose that needle length instead of the 1 inch. Although the 1 inch you'd still be able to use it in all of these patients.
Yeah, Molly, in my practice, I would always assess how much tissue I was dealing with over the muscle. And I would often use an inch long needle and just not give the whole needle. So I would make sure I get that into the muscle where I want it to be. And just assessing how much tissue there. It's not really one needle per age. You kind of have to assess the arm you're dealing with there.
Yeah. Okay.
So I think that wraps up most of the questions. Folks, I did put into the chat a survey that we'd be grateful if you'd fill it in and give us some feedback on the presentation. Molly, did you have another slide there or just maybe the ending slide?
Just a thank you slide. So just wanted to thank everyone for tuning in today. If you have any questions, please feel free to reach out to me. I'll also be sending out the slides to everyone who attended, but please fill out the survey. It's very useful for us and we really appreciate it as well. If you haven't already, follow us on our social media. We often post a lot of posts around pharmacy practice or around our programs on there. So please follow along.
All right. Have a good night, everybody. Thank you.
Thank you.